Yes, as you all very know, I'm a neurologist and we do neuro exam all the time in the CSU. I will leave and I will send an internet copy of slides. This is actually done with one of the nurses, not here in East Coast somewhere, but it does show in a very nice, simple way what, when you see a neuro exam, what to think about, where to localize it, and so on. So I am going to go through it as a cheat sheet myself. You all know about probably the FAST. It's written everywhere. ER nurses or the paramedics start with the FAST. FAST meaning the phase. The first thing you do when you walk in a room to look at the patient's appearance, as we always do. Even they are here for a chest pain, pneumonia, or some other fracture, etc. We first start talking, looking at the facial expression in the patients, and we are at the same time judging the speed, judging the mentation, judging the facial expression, and so on. So that's where it is coming from. So if the patient very obviously have a facial droop, that's the F part facial, and the speech. So you are A is the actually arm and the limb part. So when you start talking, if you notice a facial droop, if you notice a slurred speech, or they cannot express themselves, then you get a warning sign. Is it a stroke or not? Then you start asking, okay, can you hold your arms up? Can you hold the legs up? When you ask a patient to hold an arm or a leg, you have to wait them for 5 to 10 seconds because they can give a full strength up, but if they are weak enough, it's gonna drop. So they have to be able to hold it, to call it a 5/5 strength. So this is one of the things. I'm always too fast, but I kind of can guess where the problem is. So when you do there's a pronator drift, again, you have to up them. Oh, great, he is moving both. But no, wait them 10 seconds. One will start drifting eventually if there is a one-sided weakness. If both are drifting, that could be both are weak at the same time, and it depends on the location of the stroke. I will go to the location very fast as well, but we talked about the speech and the fast, not for you guys necessarily, but in ER, in the field, the time. Why is the time? Because of we give an alteplase, TPA, to the patients within 4.5 hours of onset, or if the patient is within 24 hours of a known deficit, then we can do some intervention, like the thrombectomy, embolectomy, etc. That's why the time is important. For you guys, time is important as well, but unfortunately, many patients had intervention. They had heparin shots. They had already procedures done. They already went through the blood thinners, and they may not be a candidate for a TPA. Still, we should try to find the exact onset when the symptoms started on the floor. So that is very important. And you are gonna see actually in the slideshow, you are going to be able to see what the facial droop is and arms and so on. You already know about it. Now, when we see an altered patient, many times in ER, I get saying, oh, he's altered. But when I go, he's not altered. He just cannot talk, or he doesn't even understand what you're saying. When they have this blank effect, when they are not even focusing, it doesn't sometimes mean altered. It could be a frontal stroke. Frontal stroke can affect nothing but personality. They can present with emotional lability. They can present with sudden mood change. They can present with sudden, again, speech change, not dysarthria, slurness, but it could be that they are not registering anything or they are not expressing. We do have a patient, he is totally mute, nothing else, but he is mute, and he looks very depressed and so on, but he is very aphasic. That's, for example, one of and his stroke, very interestingly, not in the middle cerebral speech territory, it is in the frontal lobe. His left frontal lobe is gone. he doesn't even speak. It was actually one of the interesting cases. So when you see no arm, leg, or facial droop, still it could be a stroke. Don't jump that, oh, he's just altered, maybe low sugar, low blood pressure. Don't rule out your stroke. That's, please keep in mind. And then if a patient has gaze deviation, that's most of the time a bleed or a big stroke. It could be a seizure too. So when you see a patient has a forced deviation, constantly looking one side, when the first thing you should do, try to ask them to follow your fingers. If they can follow the past midline, but then comes back again, that's called incomplete gaze preference, but still going to one side means there is a pathology in that side. The seizure patients, the pathology is seizure is on the other side when you gaze this, but stroke and bleed patients look at the side of the pathology. So when it is a gaze preference and they are passing but even coming back, there is something wrong in that brain. And another thing is, if they constantly look, but you can't pass them, don't confuse it with neglect. It could be neglect that you try to move the arms, legs, and they are actually able to move and do everything you're saying, but the patient is able to do everything. It could be that they had a parietal stroke, and that's why they are totally neglecting this side. And another second, it could be an occipital stroke when they are not seeing anymore, half of that vision. So it could look like a gaze preference, but those patients usually can keep the eyes on the straight. They can see your finger, they can follow your command, they just constantly prefer to go to this side. But when you try to pass, they could actually follow you and stay there. Then we start thinking that maybe there is a visual field defect, maybe there is a neglect. To check the visual field defect, you have to close either eye, you have to check the 4 quadrants in each eye. The faster way, you can look at the patient and say, are you seeing the periphery on both? But they still can neglect this side and say, oh yeah, I am seeing fine. So that's why I prefer covering the eye. I prefer showing my fingers in every quadrant. Neglect, another way to check the neglect, always to touch the patient, say which arm, which leg, which face I am touching. And the neglect patients always choose the one they are feeling, although you are touching it. So this is tricks to check for the patients who don't have a facial droop, who don't have a speech problem, who don't have arm and leg. The most common strokes, though, are either in the deep brain, basal ganglia and thalamus, or in the middle cerebral artery, which is the main artery is, and they do cause motor deficit, they do cause sensory deficit, or together, depending on where exactly the branch of the artery goes. So then it is easier. They should have a facial droop, they should have an arm and a leg weakness. The middle cerebral artery, the big parietal temporal stroke, can cause only arm and only face, not the leg. Or frontal stroke, which is the anterior cerebral artery, can cause only leg with some personality changes, etc., not the arm, not the face, not the speech. So as you see, it depends on the location of the stroke that you can see. You don't have to see one-sided weakness, numbness, tingling, although it's the most common presentation of a stroke. Another stroke location is brainstem. So that's when actually real altered patients are. They are somnolent. They cannot stay awake. Awakeness is in medulla. Vision, they have crossed eye. You see that either one eye is not worrying, or they are looking. One is not moving, the other is moving. All of those, if the eyes are not conjugate, if they are not able to look up, down, sideways, or following each other together, that's brainstem. So think of midbrain, think of pons, and think of medulla. Medulla is breathing. If a patient is stopping breathing, respiratory arrest with no reason, no pneumonia, no COPD, you know the patient came for a hip fracture and suddenly respiratory arrest, we do worry about a brainstem stroke in the medulla. If they are having a facial droop, they are having crossed eye, they are having hearing problems, and nothing is here, there's no weakness, no numbness, it still could be the upper midbrain. So it is still a stroke, even it is only the face. Cranial nerves can be purely alone affected. The reason is actually it is affecting their balance, their coordination, gait, but you're not able to see it because they are able to strength-wise move and they feel it. So no motor, no sensory deficit, yet cranial problem and coordination, dysmetria, gait, ataxic problem, etc. So that could be another brainstem stroke we worry about. I wish we could check the smell. Usually the smell, the second, third, fourth, and sixth nerves. Fifth nerve is the sensation, trigeminal nerve. Seventh is the facial nerve. These are all coming from the brainstem, and they may be affected. Most of the time, they are affected with the cross-sided motor deficit, not the same side. Usually in brainstem, they cross in the pons. So if it is upper pons, you can still see the same side, facial droop and arm leg. But if it is lower than that, you see a facial droop on one side, paralysis on other side, sensation on this side again, etc. So it can be very misleading. However, it still is a stroke. You have to worry about the brainstem. Cerebellar stroke is the very, very difficult to detect in a lying in a bed patient. The reason is they usually present with nystagmus. They usually present with severe nausea, vomiting, and vertigo. So when a vertigo happens, we usually say, oh, it's an inner ear problem. He slept wrong, or he ate too much salty food or something. So it is always very difficult to, when a patient presents with vertigo, nausea, vomiting, it actually could be a cerebellar stroke. That's why all the vertigo patients get admitted for an MRI. CAT scan can miss it, easily misses it. It doesn't show cerebellum. Or when the patients are so off balance because of the vertigo, it could be the vermis of the cerebellum, the middle of the cerebellum. They are totally fine, no slurred speech, no vision, no weakness, no numbness. The only deficit is off balance and nausea, vomiting, vertigo. Sometimes no vertigo, no nausea, they are just off balance. And these 90-year-olders come and we say, oh, their back is hurting. They already have other strokes. And why are they all admitted? Because it could be the vermis of cerebellum. It is a stroke. ER doctors are very worried to miss a stroke in just an off-balance patient. So 80% of the time there's no stroke, but 20% of the time we do find something, and then Mo has to run after us to switch the orders to a stroke order because the MRI showed a coincidental stroke. So that's why don't assume sudden nausea, vomiting, and vertigo is peripheral, and don't, in a patient with risk factors, especially high cholesterol, arrhythmia patients in cardiac unit, if they suddenly have nausea, vomiting, dizziness, we should still flag as a possible stroke too. So these are, I'm trying to be fast, to not go on order, but to give you some tricks, what symptoms that may worry you. Do you have any major other questions? I could have done it more systematically, but do you have any symptoms that you worry, or a location of a stroke that you worry? Or any challenging cases that may or may not look like a stroke. For example, memory deficits. Again, when you ask a patient, they cannot tell the time, here, and so on, it could be aphasia, not that they have a memory deficit. That also is under the category of altered mental status. We get this very, very non-specific altered, and we still don't know what really altered them. Low sugar can alter them. Low blood pressure can alter them. Taking a medicine wrongly, overdose can alter them. But they easily could be having a frontal lobe syndrome, and either they cannot express themselves or they are in a flat affect because they are not aware of the situation. That even itself can be a stroke, depending on the location. And then the bleed patients, aneurysm patients are most of the time present with a severe headache. Headache patients can be big cortical strokes. Usually small strokes should not cause headache, but I noticed that every stroke patient complains about fatigue. After they come to the office, they say, I'm not myself, even they had a little tiny basal ganglia stroke. They are healing on the weakness, etc., but they are not healing overall. So even the lacunar strokes can affect the stamina, can cause fatigue, can cause lethargy, change in the chemistry of the brain, and it takes 1 to 3 months to recover from even a small stroke. So the big cortical strokes affect the whole brain. They really feel emotional depression or insomnia or about the coordination, balance are always affected. Even the location is not cerebellum in a big stroke patient. Headache is a sign for a bleed, especially major photosensitivity, major headache. It's never a stroke. It's always something to do with the blood. Because the blood is irritant to meninges, it causes severe irritability to brain. So they become severely light and hearing sensitive, like a migraine attack. They present like a migraine. So that is a bleed patient that we worry about. And deafness and tinnitus. Yeah, I actually talked about all these vertebra basilar stroke. You have to, if a patient double vision, deaf, dysarthria, dysphagia, dizzy, and they are having drop attacks. We have one here, sudden falls with no reason, and so on. They could be all vertebral basilar artery system. So all of these could be. That's why I ordered the vertebral basilar system to look for a circulation problem on her, and that's why we have to check the balance gate to see if her cerebellum is affected, because she cannot get MRIs. So and unfortunately she hit her head, had a concussion. Now she's very dizzy. So it is so difficult. Did she have a stroke we are missing from CAT scan, or is she having a post-concussion syndrome? Because she can't walk straight. She feels terrible, very dizzy, and had a drop attack. But she had a severe concussion too. So that's where the dilemma is. That's why PTOT, we have to read the notes, how they are doing every day, and so on. Anything else I didn't cover more? Do you think this is good enough, or shall I continue, which I can?
We'll have you back again.
I have you asked if we had any questions. I
Yes.
just have a question. So we have a patient in the unit right now that presented yesterday, a direct admit, and they had been here about a month ago for some spinal surgery, which they had, and then they developed an epidural abscess. So they left this facility, they went to a rehab facility. They felt like they weren't getting appropriate treatment, so the surgeon here wanted them to come back to Mass General to be treated for the infection. So they were brought by ambulance for a couple hour ride, and they arrived yesterday, and so they were originally admitted upstairs to the and so they were kind of concerned about his antibiotic treatment and the epidural abscess and the infection. So he arrived yesterday via ambulance, and they originally admitted him upstairs to the 4th floor, and within moments he started having really bad expressive aphasia. So they did a rapid response and they transferred him down here. So he had a CT which was negative, and he had an MRI which was negative, but he definitely has a facial droop and expressive aphasia.
Yeah. See, even actually is a very good question. We see it once in a while. MRI could be negative and it still could be a stroke. So he should be treated like a stroke, no matter what. And I am, again, worried that it could be a mini brainstem problem. On the other hand, they have to MRI the cervical spine, the abscess. If there is an infection going, it could go to the brainstem.
Right.
It could affect the cranial
Good
nerves.
point.
And
Hadn't thought about that.
yeah, so he really should be checked for meningitis, abscess in the upper part, etc. So the stroke can happen from infection itself. And it is treated not with blood thinners but with antibiotics. So definitely they need to continue with the workup. That MRI has to be contrasted in the brain and brainstem focus, and a cervical spine MRI with contrast needed on it.
Okay, that's such good insight. I went home last night thinking about it.
Yeah, so it could be, yes, basilar meningitis, for example, TB, Cryptococcus, HIV can cause those things a lot.
Okay, thank you so much.
I know. Thank you so much for being here, despite of all the